आयो होला अब
भयो हुन्छ ल फाइन ल लाइभमा आयो हुन्छ गुड म लाइभ लिंक पनि शेयर गरिदिँदैछु ल हाम्रो ग्रुपमा ओके गुड 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 दामी
Dr. Prerna आउनुभयो निकिता
हजुर गुड इभिनिङ डाक्टर प्रज्वल
Good evening. Nikita, you can start now. अब सुरु गर अब
नमस्ते Namaste, good evening everyone. I am Dr. Nikita Bhattrai. A warm welcome to all the participants for this webinar. It has been organized by the Nepalese Society of Community Medicine, NESCOM. Today we will be talking about NCD epidemic in Nepal. We have here with us Professor Dr. Abhinav Vaidya, who will highlight where are we actually heading in terms of NCDs in the 21st century. A gentle reminder before we start that the participants can freely use English and Nepali language and switch between them. I request everyone to please mute their microphones when they are not speaking. You can use the chat box for any questions or queries that you would like Dr. Abhinav to address. He will be discussing them all at the end of his presentation. Please raise your hands if you want to add something to the discussion later on. I would like to inform you that this webinar is being recorded. Without further ado, I would like to introduce our speaker. I would like to introduce our speaker for today. He actually needs no introduction because he's a very familiar name in the field of community medicine and NCD, and it's an honor to have him today share his views and experiences. So let me start by reading out his bio. He is Professor Dr. Abhinav Vaidya. He is currently the Senior Vice
Nikita, your screen is not visible.
Yeah,
okay, okay. Just came.
Visible.
Yeah.
Awesome. So let me introduce again Professor Dr. Abhinav Vaidya. He is currently a Senior Vice President of Nepalese Society of Community Medicine, NESCOM. He has done his MBBS from Bangladesh, and he has done his MD Community Medicine from BPKIHS, and he has done his PhD in Medical Sciences from Gothenburg University, Sweden. He is a faculty in the Department of Community Medicine in KMC from 2006, and he has mentored many postgraduate and PhD students. He is the Secretary of Association of Health Profession Educationalists of Nepal and the General Secretary of Nepal Public Health Foundation. Besides academics, he has been involved in NCD-related research, policy development, projects, advocacy, and health promotion. He has led teams that have worked on the development of basic service health packages and emergency healthcare packages for the Ministry of Health and Population of Nepal. He was also involved in the document development of PEN package and multi-sectoral NCD action plan 2013 to 2020. He is the principal investigator of NIH-funded BRISK project that aims to build research capacity for prevention and control of NCD risk factors in Nepal. He's a Lone Scholar in Cardiovascular Health at Howard T.H. Chan School of Public Health. He functions as a member secretary of Nepal NCD Alliance and as a governing board member of Southeast Asia Region NCD Alliance. I would like to welcome Professor Dr. Abhinav. Thank you for taking out time to be with us from your busy schedule. The webinar will be moderated by Dr. Prerna Bansal. Let me introduce her to all of you. So Dr. Prerna Bansal, she has done her MBBS from KMC, and she has done her MD in Community Medicine from KU, and she has done her fellowship in diabetes. She is currently the assistant professor in the Department of Community Medicine at College of Medical Sciences, COMS. She leads in medical education and research as academic coordinator, and she's a member of Institutional Review Committee. She's also the PBL and Community Health Service Coordinator at the College of Medical Sciences. She has worked as a focal person and coordinator to Government of Nepal for the implementation of prevention and control measures in the COVID pandemic in Chitwan. Her research areas are focused on communicable and non-communicable disease, maternal and child health. So I hand over the floor to the moderator. Prerna ma'am. Prerna ma'am, I hand over the floor to you.
Good evening, everyone. Myself, Dr. Prerna Bansal. I'm the moderator for today's webinar. I'd like to welcome once again you all to this webinar organized by NESCOM. Amidst the pandemic of an infectious disease like COVID-19, we have been also, the health system has been suffering from underlying many other health problems. Amongst that, one of these is also the non-communicable diseases. The morbidity and mortality of the non-communicable disease has been speeding up and increasing drastically with every day. So to address this issue and also to discuss such health problems in platform like these, we have been conducting these webinars, and today we have our renowned Professor Dr. Abhinav Vaidya, who has worked in this field with his experience and expertise. Will be discussing on today's topic, non-communicable diseases epidemic in Nepal. And also he'll be enlightening how are we heading it in the 21st century. So without any delay, I'd like to hand over the program to our speaker for today, Professor Dr. Abhinav Vaidya. Following the webinar, his presentation will be heading over towards discussions and other sections of the webinar. So over to you, Abhinav, sir.
Yeah, thanks a lot, Nikki and Prerna, for your introduction. Let me pull up my slides. As far as I can see, it's now shared. Can someone please confirm if it's visible or not?
It's okay.
Yes, sir.
Okay, great. Yeah, so the topic that was that we discussed, that we will present and discuss today is, as said earlier, is the epidemic of NCDs in Nepal. And so these are the few things that I'll cover in today's presentation. Many of these things will probably not be new to you. You must have read it, heard about it, lived through it in many forms. But I'll try to cover which are important, mainly from the perspective of either public health personnel or soon to be graduate in the field of community medicine and public health. So I do not claim actually to be an expert in the field. I know that I'm not, but probably somebody who has experienced the different areas that we are discussing today. So that probably makes me eligible enough to speak about it. So I still feel that I'm a learner. I'm a scholar of non-communicable diseases. So still a far way to go to become an expert. And probably, I would never want to be an expert, to be very honest. Most of the things that I will discuss today or talk about will be targeted to the young graduates, like I earlier said, but there would be things that I think we can go beyond just the elementary things. So while preparing, I have not, I didn't intend or do not intend to talk about the basics of what is community medicine and things like that, but right away into the, the crux of the things and where we stand in terms of all the things in NCDs. So when Prajwal actually communicated to me about the title, I said, okay, this is okay, this is, but are we really in an epidemic? That got me thinking. So I actually looked around for evidence to prove or disprove that, you know, it is indeed an endemic that we are facing. And there were many titles, of course, if you were to look at the different publications, but to be very honest, it's very difficult to say epidemiologically, you know, if you were to go by the definition of an epidemic, or you know, the different formula that you'd have and the data that you'd need, it's really difficult to actually say. But nonetheless, you'll see that many articles will actually use the word that it's rising or it's increasing, because whether it's a common man or it's a professional, all of us kind of sense that it's rising. We also can look at various data that are available from various, let's say, hospitals or other health facilities. And if we were to, for example, look at this data from Gangalal, you'll see that compared, it's a little blurred, but from 2002 to 2018, the number of OPD attendance has got, you know, just skyrocketed. So it may get you thinking that indeed the number of cases have gone up. But if we were to think of the population increment, if we were to think of the rise in the services that are available in the hospital, if you were to think of the referral system in the country and so many other things, you will really need to think whether it is indeed, you know, really, does it really reflect the rising cases? It may be true, but you know, this is not a sufficient evidence. I also looked at the recent annual report from the Department of Health Services, and likewise here in the first graph, you can see that, for example, the hypertension cases is going up like anything. This is number of cases. Similarly, diabetes cases and the COPD cases, they seem also to be rising. We cannot say the same thing about the cervical cancer or the breast cancer, but at least for cervical cancer, for the few years, they seem to be going up. Now, again, like in the first diagram of Gangalal, this could be very much linked with the starting of the pain program. So more diagnoses, more cases, and so more reporting. So we cannot really say on the basis of these graphs that the cases are rising. We in fact had only one prevalence study done on the major NCDs in Nepal. That was about 3 or 4 years back. And that showed that the prevalence of COPD at the community level is almost 12%, the highest in fact. Diabetes is much higher than we thought it would be, around 8.5%. Chronic kidney disease is very common, again, more than we thought it would be. And unlike, you know, what we would think, the coronary heart disease is around 3%. So COPD actually wins the race when it comes to the thing, but we don't know yet with this evidence that it is really increasing or not. I wouldn't go into the details of this next graph, where you can see the prevalence in terms of different provinces. But you can note, for example, that COPD is around 21% in Karnali province, which is very high. Diabetes is very common, for example, in the province 3. So this could be linked, you know, with the more prevalence of risk factors in these places or in these provinces. We also have, you know, data from the estimates. So that has actually been the more common, let's say, the source of information as far as the trends are concerned. And so if you look at the one that we reported in the National Nepal NCDI Poverty Commission, you'll see in this graph that the red one is the communicable, the dark blue one at the top is the injury, and at the bottom, the grayish one is the non-communicable diseases. And if you were to think that, a straightforward interpretation of this would be that from 1990 to 2015, the cases seem to be going up. But what has actually happened parallelly during the time is that the communicable diseases have also shrunk. Just be mindful that this is actually percent of total DALYs, which means that if the communicable diseases, maternal health, neonatal health, all those indicators, they improve, the other things are bound to, relatively go up. So it doesn't mean that the cases have really gone up. It means that the share or the percent of those other diseases like injuries or other NCDs can actually go up. So this also is a very tricky graph in that sense. You can also look at these GBD data, which Nepal has also published in 2017. And you'll see here that some of the non-communicable diseases have actually gone up. For example, from the position of 10 to number 1 for ischemic heart disease, or also for other which are in blue here. But again, this is actually percentage of total DALYs. So it means that they topped because, or could be, I cannot confirm, but it could be because the other infectious diseases like lower respiratory tract infections, diarrheal disease, they have gone down. Among all the estimates, there is one graph which was done actually by our colleagues, Manita and others, Dr. Baral and leading this team, which actually may hint that, the cases are actually rising. So if you were to look at the first 2 lines, which are for male and the females and incident rates for the cardiovascular diseases, then they do seem to be going up. Fortunately for mortality, at least for female, it's kind of a flat, but one part of this graph, which may be a little terrifying, is that the mortality rates for the males, they seem to be going up, or at least they went up between the period of 2005 to 2015. So in conclusion, regarding the okay, that was a small break. Maybe somebody wanted to say something, or there was some background music as well. So anyway, so let's say that we cannot really say that we are in epidemic, but by the global trends and with evidence that we have, NCD definitely is a major health problem. Now, but at the same time, if we look at the risk factors instead of the diseases per se, then there are good and repeated measurements done over the last few years, or almost now 1.5 decades, and we have strong evidence that at least some of the risk factors seem to be on the rise. So for example, physical activity, if we were to compare with the previous data, it seemed to be on the rise. Likewise, the fruit and vegetable having less than 5 servings, it has always actually been suboptimal, and so it's there. But the worrying part, in fact, are the rise in the BMI. Whether you measure the overweight or obesity, they seem to be on the rise. And if you were to look at this for specific population, like maybe young children or urban population, this would actually give us a more disaggregated data, and where you will see that the trends are in fact quite let's say eye-opening for BMI. Okay, with this background, so what happened to the policies? In fact, if we were to look back at the policy and how NCD related policies have evolved it's a very good historical perspective that you can get. I'm not going to details of this, but as many of us know that, the first health policy, mic is on. Probably if it can be turned off, it will, if muted, probably it will be better for others to hear more clearly. Thank you. The second long-term health plan followed that, and then we had these Nepal health sector programs, 1, 2, and then 3. We had several editions of the national policy. Finally, we had the one that was passed by the parliament in 2018. So if you were to look at this from the perspective of Nepal, NCDs, then the Nepal health policy of 1991 was mostly trying to take the primary health care to the rural population. Whereas the second long-term health plan was mostly a guiding framework for implementation of the plan, of the policies. And it was around 2004 where, the prevalence of NCDs as estimates started to come up. But then it was kind of, the policymakers kind of excused themselves, I would say, by saying that, okay, this is still not very high enough for us to be really worried about. So, it was just put like that. Nothing further was mentioned there. And then around 2010, when we had the second NHSP, there the activities by promoting healthy lifestyles, and so there were, like, for example, indicators related to tobacco reduction, alcohol reduction, and so forth. But there were no programs that actually addressed those indicators. But then by 2018, of NCDs, and even like some specific things regarding NCDs, like the occupational health, genetic disorders, or chemical exposures, they were also okay. Look like
I think
was,
the presentation, we need to share the presentation again.
Okay, so
Okay. Over to you, sir.
okay, thank you. Yeah, so it was only like very recently, as you will note here, that NCD was taken as a serious issue, and so the policy documents addressed in terms of capacity, leadership, governance, and research, and so forth. Okay, what actually drove this changes in the policymakers' heart was in fact the global health, and it was the driving force. And it was at the end of the or starting of the MDG that there was this global strategy to prevent NCDs, but it was kind of a document that stayed within the NCD people. It didn't come up to MDG, as we will see in a while. And then we had this action plan in 2008, but it was the third document in the series, the one which came out in 2013, that actually laid the foundation for our own activities as far as NCDs are concerned. And because we are now, already finished 2020, so the work plan for the next global action is actually on the way as we speak. But this document, that one which came out in 2013, was actually the basis on which the South Asian targets, indicators, the goals, everything came up. And it was on the global and the Southeast Asian document that we had our own multisectoral action plan. So it was a a very historic moment in many ways, because it was for the first time that Nepal had come together to make a document that would address the NCD issues in it. And following the global and the regional targets, the target was to reduce the premature deaths by a quarter by 2025 and by a third by 2030. There are several indicators if you want to look at the details, but I wouldn't go elaborating them. So there are indicators for or targets for alcohol, for tobacco, for solid waste, solid fuel, for sodium, for blood pressure, diabetes, and so on. So this is the complete list of indicators that were put in the document. One interesting thing about the multi-sector action plan was the inclusion of 3 additional diseases or NCDs which were not present, in fact, in the global document. And also there was one additional risk factor put, indoor air pollution, which was not present in the 4x4 model, as many of you already know. So this was a kind of a pioneering work, if you consider, Nepal's stance at that point. In fact, mental health now is a part of the 5x5 frame, which is a deviation or let's say an upgraded form from the 4x4 framework. And air pollution, not only indoor air pollution, but air pollution in general is also now put as the 5th risk factor in the 5x5 framework. Now, I think we need to go a bit deep into the this multi-sector action plan, because it was the basis on which we had different activities and programs. It had, theoretically speaking, it had a very good foundation or background or intention, for example, to address the leadership, advocacy, and partnership, health promotion and risk reduction, health system strengthening, and then surveillance, monitoring, research, etc. It did achieve a lot of things, because on the basis of this document, NCD was actually featured in addition to what I said earlier, in like the National Health Sector Strategy, Public Health Service Act, Health Service Regulations, the 2nd Multi-Sectoral Nutrition Plan, the 5th Fiscal Plan for everything. So this was a good start, and in fact, it can be claimed that it has achieved, because on the basis of the activities that were done, on the basis of this document, Nepal has achieved a lot in terms of, like, we have now the national targets and indicators. We are regularly doing the risk factor surveys. We have a national action plan on NCDs. There is a tobacco control policy, pictorial warning, ban on tobacco products advertisement, taxation on alcohol, and restriction on the marketing of best milk supplements. So these are some of the achievements. So if you were to look at the, what are the lessons learned from this 5-year period of the implementation of this multi-sector action plan, then, the realization is that there is more commitment needed at the top level. There is, the document doesn't function on its own. It doesn't get implemented automatically. So it has to have a, a better commitment at the top political level to move this forward. Next thing was, because this is a multi-sectoral approach, so the whole of government and whole of society needs to be involved. It cannot be done by a single sector. And the third thing that actually was the reason for the, the reason why the document couldn't be implemented as it was intended was that because Nepal went through the federalization, and so there were various levels. So there was a lot of reshuffling and all those things. So to implement something new was a struggle, because even for the routine things that were being done during this time, it was difficult for the health system to implement. So that was additional barrier. And most of the time, even if though it was a multi-sectoral program, it was taken as, the focus was on disease control by the health sector. And also another reflection that came up was that maybe we should try to do it like for other disease control programs. So we have to learn the lessons that are there. So from that learning and from that experience, so for the new multi-sector action plan that is yet to be released or implemented, so these things are taken care of. So I will not go into details, but like, for example, establishment of NCD division and liaison persons in the line ministries, mainstreaming of the NCD related activities, to ensure that there is NCD related people in the provincial and local level bodies, budgeting accordingly, and ensuring that the cost and the financing mechanism is taken care of, and also to ensure that the monitoring and evaluation indicators are really promoted. And finally, what I had also written in one of my papers, that capacity building to implement this is lacking. So we really need to have people who can actually implement the things that we have said that we will write, will do in the document. So this is also taken care of in the document. I like to call some of the risk factors as neglected risk factors. Tobacco, I think, is very fortunate, and it's actually very lucky that it has got so much attention in the form of Framework Convention of Tobacco Control and the Tobacco Control Act, for example, in our country, though implementation is still questionable. But there were actually some other documents, but it never went to the level of kind of this convention. That's why I call them neglected. So these are like the global strategy for diet and physical activity, and also one for alcohol. But these are reflected more or less in what we call as the WHO Best Buys. So you must have heard the term, and the WHO Best Buy is essentially if the intervention, if we do the cost effectiveness analysis, then the cost is less than $1 for 100 dailies averted. So that is the definition of the Best Buy. So I will not go into details. For example, there are things, as you may already know, regarding tobacco, regarding unhealthy diet, like salt and exercise, regarding cancer, harmful use of alcohol, CVD and diabetes, and so on. But there is actually, monitoring of what progress has been made. And so according to the latest progress report, which came very recently, in fact, you will see that, don't go into the details, but just if you were to look at how complete the circles are. So, that basically gives you the idea of whether we have achieved that or not. So you'll see that there are more completed circles when it comes to the tobacco, but much less when it comes to unhealthy diet. And likewise, for, let's say, alcohol, there is a progress, there is good progress going on. Similarly, for, you can look at the other details in the document. I will not go. Sorry, I have electricity gone at my house, I think after, I don't know, many years suddenly. So you'll see that I'm in a little darkness than before. Okay, but there are, like, good things that, tobacco and the empower, I'm sure but the other things, for example, the alcohol, the safer strategy, and for the the replace therapy or the replace for the salt, they are actually coming up. And so or for, let's say, for the for saturated fat, they are actually being implemented in the coming multi-sector action plan. Now, coming to the NCD services, I think the one program that comes to all the mind is the PAN package, and this in fact is the key program for the country at the moment. I will not go into details of this, but as you know, it has got 4 protocols, and it is being implemented gradually across all the parts of the country, all the districts, and it addresses mainly the hypertension, diabetes. The second protocol is about the health education and counseling to the patients. Third one is on COPD, and the fourth one is on 2 female cancers, you can say breast and cervical cancers. Now, if you were to look at the NCD services on the whole in Nepal, I have tried to put it in the form of various levels of prevention and across the different levels of prevention. Now, this table is still a work in progress, and in that sense, it may not be complete or sufficient. But what I'm trying to show here is that, as you well know, that most of the secondary services or tertiary services would be given at either super specialized government hospitals or private hospitals, at the maybe secondary level, at the district level, and so forth. Whereas the primordial prevention activities, mainly in the form of health education, we have these pamphlets or posters, etc., more at the community level. And what I feel lacking at the moment, one, is there are no primary prevention levels, activities or services. So for example, or it's very, let's say, very limited. We don't have, let's say, if somebody wants to quit tobacco, the services are very limited. Or if somebody wants to cut down on alcohol, for weight reduction, those things are not there, or are available in a very limited settings. So these are important. What I feel also important is are some of the the interventions that are done or are being planned at a very, let's say, a pilot level or at a subnational level. These are like, for example, the MUTU project that I'll talk about in a moment, or also the PAN Plus package. These shall be very important in actually kind of bridging between the communities or the primary healthcare services and the referral centers. So for continuum of care, we need to have the programs which are more aligned with programs like this. There are many community interventions. The Hardik trial that we did in Bhaktapur, the Govind trial in Kaski, which trained the FCSBs for detecting NCDs, school programs, interventions like the BCS study or the Tulkel Health Art study. These are all very well documented programs, or let's say the projects. What is needed is that the government needs to look at the data and scale them up. There's a bright spot here. What is kind of, let's say, okayed by the ministry, I think, is the framework of community intervention for prevention of control of NCDs. So this framework will actually address the all the little things that could be done at the community level. And I think this framework should try to bring together the experiences that I've learned from the smaller pilot projects done across the country. There are health facility interventions as well. One was done with initiation of BPKHS, and I'm sure many of you must have heard the term or the abbreviation cohesion, in which many of our colleagues of BPKHS was a part of. Similarly, there's an ongoing MUTU program, which is on hypertension, and here the task shifting is being done. So the health care providers in the health posts, they actually give the treatment of amlodipine, and they prescribe it, but they also have the supervision done by the physician. We also have the Pain Plus program, which is a bridge between the pain implemented, let's say, health facilities like Health Post and the PSCCs and the centers which will receive the patients from those centers. So this is a kind of a path-breaking program that is being rolled out very soon. Now, why we need to think of the services and the potential gaps? It is mainly because we want to achieve universal health coverage, and it is not possible to achieve universal health coverage without addressing the NCDs. So whether you talk about the services, which would mean that you need to fill in the gap with the NCD related services, or you want to reach out to the people who are not covered yet, or you want to think about the how we can minimize the out-of-pocket cost, etc. In all these things, we will need to think about the NCDs. And if you were to look at the universal health coverage indicators, this is the most recent one, you will see that the overall index is 48 for Nepal, and for NCDs it is 62. So all these things will need to actually go to 100 to achieve 100% universal health coverage. If you notice in this graph, actually for infectious disease also, it's almost similar, which means that we need to do a lot of things in the field of communicable diseases as well. A very closely related term is the SDGs. And as you know that when we had the MDG, there was nothing about the NCDs. So when we completed the MDGs in 2015 and we started into the era of Sustainable Development Goals, so we had the third goal, and within that goal we had a target 3.4, which was about the non-communicable diseases. And so 1/3 of mortality prevention from NCDs by 2030 is the target. And because now we have NCDs within the SDG, it I think is a very important leverage point. It means that the global attention is there for the NCDs, and this must be utilized by the government and other sectors to bring in more technical and other supports. I will not go into the details of the SDG as such in terms of progress. You can see that there is one indicator available for example, for the combined thing, but I don't know how good this data is, and there is no data available for separately for example, for CBD, cancer, etc. So, I mean, whether we're talking about SDG or not, we do need robust data as far as NCDs or any other health indicator is concerned. Now, one area which has been really neglected, I think, globally as well as locally, is the advocacy part. In fact, there are now global, let's say, leaders in this, which are actually, for example, participating even in the UN, these high-level commission meetings and putting forth their voice. So this is actually an important aspect of NCDs. And there are many programs, and for example, one of them is like, for example, the Our Views, Our Voices program, which is totally about the patients and their viewpoints on decision making. Now, we also do have many, let's say, the organizations in Nepal, and we have come together in the form of Nepal NCD Alliance, and we are part of the Southeast Asian as well as the Global NCD Alliance, and we in fact are recipient also of an advocacy fund that will be used to make our programs and so forth. But what is lacking in all the advocacy activities, I'm not saying like in terms of Nepal NCD Alliance or in particular organization within Nepal, but I feel that advocacy is done mainly through professionals, by the experts, but not by those, or by including the people who are really suffering from them. So this, I think, is an important lesson that we are learning slowly, and we need to involve all the stakeholders is something that is, that is the opinion all across the globe. Economy, if we don't talk about finance and economy, the lecture will be incomplete. However, if you were to look at the relationship between NCDs and economy, it's complicated. Let's put it that way. But if you were to kind of think about it, if you were to kind of streamline them or segregate them, then basically it will be like, what will be hit? This economy that will be hit if we have more cases of NCDs. The health system will be hit. It will be households and individuals, the families that would be hit by the rising NCDs. And there will be like the financial pressures. There will be, impact on the country's productivity. The health outcomes will be worse. There will be basically more of poverty, more of inequity, and so on. I will give you some idea regarding how Nepal is in terms of high-income countries. Because if you go back, let's say 20 years or so, the NCDs were thought to be a problem, mainly of the high-income countries, right? So that's what the policymakers probably thought, because we didn't have evidence as well. But if you look at these graphs, now the first one is for the non-communicable diseases, and you'll see here that the global or the compared to high-income country, the GBD daily rate is not that low, isn't it? So, but if you were to compare for other conditions like the communicable, maternal, neonatal, it is very high compared to, this is expected compared to the high-income countries. For injuries also, Nepal has a worse daily rate compared to high-income countries. Probably this is also expected. But my focus here is on the first pair of bars where it is still quite high. Now, if you were to look at how are things within Nepal, through the Nepal NCD Poverty Commission, we have done this study, and looking at the various, let's say the index or the component of index, and then comparing the dailies, we came up with this graph. Now, again, within Nepal, if you were to compare the dailies or daily rates between, let's say the poor, which is in the faint blue, versus non-poor, which is in the darker blue, you'll see that for most of the disease conditions, these are all NCDs, you'll see that the bar is longer for the poor. So which means that the poor are affected more. For example, for ischemic heart disease, for COPD, for hemorrhagic stroke, for asthma, for rheumatic heart disease, and so forth. So within Nepal, if you have to think, then it is disproportionately, or we can say that it's the poor which are hit much harder. Another piece of evidence that I would like to put here, done through the Nepal NCD Poverty Commission, again, is the fact that is the what is called as the impoverishment impact. And it is like the incidence of poverty for 100 cases. And you'll see that, it's the injury which tops the list, but it is heart disease that comes third. And then there is asthma, blood pressure related complications, diabetes, and so forth. So you can see that the NCDs are actually leading people to become more and more poor. Of course, now if you do this again, COVID will, really top the list. And this kind of impoverishment was also addressed in a very recently published qualitative study, where I'll just read one line from here. The situation forces people to choose between avoiding medical treatment or for further impoverishing their families. So people are, they have to choose between whether they want to spend their money on their own treatment or, ensure that their family doesn't get poorer. So this is a sad story. This is also because the financing in NCDs is very, very low. So if you were to compare between, for example, the proportion of NCDs in terms of debts and the funding for 67% and 2%, this you can see that it's really, really unfair. If you were to look at Nepal's data, 1/3 of health expenditure is on NCDs. And half or more than half of the total out-of-pocket expenditure goes to NCDs. It is for NCDs. Government right now is spending around 6.4% of the total government expenditure. Only 6.4% is for NCDs. And the external development assistance is also very poor. So there is expenditure, but there is less budget. There is less assistance. So which means that it will mostly be the out-of-pocket expenditure when it comes to NCDs. And there are many programs which actually are addressing it nonetheless. So you must have heard of this Vipanan Nagarik course, and many, let's say the tertiary care services are being covered by this program, around like 1 lakh, 2 lakh, and like that. I'm not going into details, but many times you will feel that, is this just a populist move, or are they really helping? Because, we are not addressing the, the downstream. We are not addressing, for example, upstream, for example, the primary prevention or the secondary prevention. Okay, now something that we are, very familiar with, or, we do a lot is the NCD research. I would say that, the NCD research is, we have an epidemic of NCD research, which is a good epidemic, I would say. If we were to go back like 1980s, there were hardly any publication. There was like, for example, I put forth a landmark publication done by Dr. M.R. Pandey, who is the NCD pioneer in the country, on bronchitis prevalence in a rural community. So we then, have come a long way since then. In the earlier part, we had, mostly cross-sectional studies. We did risk factor on tobacco, smoking. We did, for example, at the most, maybe some blood pressure studies. We couldn't do diabetes study. From there, we now have entered an era where we do, on a 5-yearly basis, the STEP survey. We do like, blood test in it. During the last 5 years, it has now changed into more advanced things, you can say. For example, we have done now registries. We do analyze secondary data. We report meta-analysis. We publish systematic systems research, policy analysis. We are now into the era of implementation research. We have a lot of, let's say, interventions, pilot projects on digital interventions. So we are really progressing. We regularly see these publications like on the, systematic review and meta-analysis. So we are really into a golden period as far as NCDs are concerned in terms of research. We actually haven't published this yet, but still there are a lot of things that we need to do. In terms of quality and in terms of quantity, we are flourishing, no doubt. But when we asked, when we actually did this kind of a small review, we found that most of the studies are still observational. And that too cross-sectional. It has become a kind of a trend to have small cross-sectional study in a small municipality, for example, a thesis and like that. So, I mean, they are all good, no doubt, but it is actually limiting the kind of research that we are doing. More than half of the published articles are in international journals, which is, I would say, a good thing. At the same time, almost all the articles were without any finance. At least the financial support was not mentioned, which could mean that either we are lacking in terms of research support, or people are not reporting it. I mean, it could be anything. So I will not comment much on this. We, during this study, asked about the research, NCD research, and how do the postgraduates they perceive. And so they are quite geared up because there are trained human resources. There are international donors which are apparently very keen on giving funds for research, and even from within the country, I think NHRC has played a big role in pushing the NCD research, and so that have actually motivated the young minds. But at the same time, they felt that the curative aspects are given more priority. There is not enough training yet. For example, for advanced research tools, we, for example, haven't done cohort studies. Our cities are also very limited. Also, there is lack of capacity building activities. Also, from institutional point of view, there is underestimation of research values. There is lack of, or let's say, inadequate research culture. And what is needed in NCD, in fact, is a multi-sectoral or interinstitutional collaboration. That is also lacking. We are, in our own silos most of the time. Okay, so that brings us almost to the close of today's presentation. And so I would like to end with this final slide, which is about scope in the field of NCDs for young graduates. There is, if I were to answer this in a single question or single word, it would be that, yes, there is scope, a lot of scope. But can one just hold, can one have a career entirely dependent on NCDs? I would say no. Still, you have to have something, and then only you can have, NCDs as you're moving ahead. You have to have some base camp. You have to have something that will provide you with bread and butter and everything. There is now there are a lot of opportunities, no doubt, but there are still, this is still, you can say that whether in service, whether in research, whether in academics or policy, still more needs to be done. For example, I did PhD in non-communicable disease subject. It is not recognized by, let's say, KU that, okay, I have done something additional. For KU, I am still a MD community medicine. I can never become, for example, professor of cardiovascular health or something. So this is a major limitation. So you may be doing things, but you are still not very, let's say, acknowledged for the things that you've done in terms of like, affiliation or those things. Similarly, my PhD is not, let's say, doesn't hold anything more than my MD when it comes to the Nepal Medical Council. I'm still, let's say, a MD in community medicine as far as medical council is concerned. But if you were to not, get affected by these things, then, there is a lot of potential for you to do further studies. You can do, masters in certain subjects within NCD. You can do, for example, PhD. There's a lot of scope. So if you do not think about, whether your degree is recognized by university, etc., then you can do a lot. Similarly, you can do a lot of policy influencing. This is, something that I have done. This is something that seen my colleagues who are in NCDs doing. So whether you are a policy maker or not, you can still do a lot of policy influencing. Of course, if you were to go into the government service, if you can, do that, then of course you can do the policy making yourself as well. In global health, again, like I said earlier, there's a lot of scope. So, the globe, you can say that the globe is not the limit. You can go to a lot of places. You can actually apply for a lot of different positions in different places and work as people who run the NCD related program. In terms of service, especially for those who are from the MD community medicine background, there's a limitation, but this is something that is changing, and I know that it will be soon when we have people in services, and also for others, in service, of course, there is a lot of things that can be done in NCDs. In advocacy and in working in civil society organizations, this is something also coming up, but you cannot really just advocate and think that you can run a family or a household. So this is something you can do as an additional thing. You have to do it, but not as the main profession at the moment. Okay, so that actually brings me to the my mic is also dropped, so that brings me to the final slide. Thank you very much for listening. Over to you, Prerna. Maybe I went a little bit overboard in terms of time.
Thank you so much, Abhinav sir. That was a very informative presentation, and I would really congratulate you. Within a span of time, you have given us so much information and included a lot of aspects about NCD's epidemiology. And now, before going into the discussion part, we would like to introduce an icebreaker so that we can again get back to the topic. And so for that, I'd like Dr. Surya, please, to.
Dr. Prerna, मसँग छैन त्यो Dr. Prajwal नै गर्नुहुन्छ होला मलाई हस शेयरिङ गरेको छैन अहिले
Okay, Dr. Prajwal, are you ready, Dr. Prajwal, or shall we do it later so we can move forward to the discussion?
Dr. Prajwal तपाईले नि गर्नु न यहाँबाट भइरहेछ नि
Okay, I think there is some technical issue right now. Okay, so we have these questions flashed in the screen. Yeah. So I'd like to inform all the audience. So there's a small poll, so you can see into your screen, and it's a single choice. So I request everyone to just put on their answers, and you can submit it. And let's see what the answers comes up. I request everybody to want to participate. So you can submit, click submit after you have answered all the 5 questions. We have total 58 participants right now. So once the poll results are there, can we have the results now? So we have a comment like very difficult questions. So it is, I think, about our society. So how well we know about our society. So let's have a look. Are we ready with the results?
Dr. Prerna, please read out the results I've given to you.
Okay. So we do have the poll. We do not have the poll on screen. Can we display on the screen? Okay, so our first question was, when was NESCOM established? So the correct answer is 2016. The second question was, where does the current president of NESCOM works? And the correct answer is NAIHS, National Academy Institute of Health Sciences. Our third question was, who is famously called the father of community medicine? So our very own respected Professor Nilambar Jha. And fourth question is, how many females are there in the executive committee? So the correct answer is 5. And the last not but the least, the fifth question is, how many participants do we have? How many members do we have in the NESCOM community? And we are very happy to announce that we have over 100 residents and graduates in our society. So this was a quick questions on about the NESCOM, Nepalese Society of Community Medicine. So how much we know about our own society where we are related to. So just for an icebreaker and just to break the monotony, we had this small quiz. So let's get back to our discussions. So if we have any questions, you can raise hand. So we have Dr. Samta Nepal answered 4 out of 5. So I think we should meet properly. We should mingle more on our members and know more about ourselves. And so let's head over towards the discussion now. So if anyone has got any questions, you can raise hand. And so meanwhile, we had, I think Dr. Rajan Raimaji, Dr. Rajan has got some comments and something, so would like to unmute and speak. Dr. Rajan, are you there? Dr. Rajan mentions that it would be nice if more elaboration could be done on multi-sectoral coordination with the line ministries and pen package rollout in the country, including its compliance in prescription. So Abhinav sir, would you like to address it?
Okay, thank you for the question, Rajan, and Prerna for getting it through. Of course, I'm not the best person to respond because I am not in the implementation part. But from what I know and what I've understood is that maybe it's true also for many other, let's say, activities or agenda that requires people to work together. But okay, so Rajan is outside with a lot of noise. So think about the situation where something needs to be done by bringing together different ministry people on a single agenda, and then there are it's not for a single, let's say, it's not only for, let's say, how to improve physical activity. You need to bring together to different ministry for, let's say, indoor air pollution and things like that. So it is expected to be difficult, and so that was what happened. I recall that during the first, these 5 years of the implementation of the multi-sectoral action plan, I think up to 3 years, for 3 years, not even a follow-up meeting could be held between the ministries. It looks very nice on the paper. Ki, यो मन्त्रालयले चाहिँ यसलाई लिड गर्छ, यो मन्त्रालयले चाहिँ यो काम गर्छ, and like that. तर वास्तवमा त्यो गर्ने हुन्छ केतला काम सक्यो, पेपर बन्यो, डकुमेन्टेसन राम्रो भयो, सक्यो जस्तो हुन्छ. It's very, very difficult to bring people together. I recall one moment from I've shared this with others also. जुन बेलामा त्यो multi-sector action plan बनाएको थियो, during that time, during those meetings, during those workshops, so we had these round tables as we have in the different workshops, and on each of the table there would be like यो जुन हाम्रो अब कसले चाहिँ कुन हेर्ने भनेर जस्तै अब there would be like one folded paper on diet, physical activity, tobacco, and like that. त्यो जुन table physical activity र diet को थियो, the table were always vacant. Even during the formulation, त्यो बेलामा पनि त्यो related मन्त्रालयको मान्छेहरु आएको थिएन. So that's how things are. So in terms of, so that's why I'm saying like that was a reflection that was taken up by I think the when I showed you the reflections learned from other lessons learned from the Multisector Action Plan. Again, regarding pain, you know, there are a lot of problems indeed when it comes to this implementation. Whether it's like, you know, pain program cha, trained staff cha, chaina, because the trained pain staff actually has been, you know, transferred to someone way has been shifted somewhere, transferred somewhere. Pain package cha, that also China. So there are a lot of problems. This is like, you know, not a, I would say, unique only to the pain package, but for a lot of other programs as well. But I'm sure, like, you know, it will change over time. It will get better only. It won't get worse. So I would say that, you know, and I'm sure with the strengthening of the local level, which I think is the most important thing, and strengthening of the provincial level to monitor, the pain package will only get better. Yes, thank you.
Thank you, sir. I think Dr. Rajan, he cannot take the call, but I think most of the things has been addressed. And obviously we can have a detailed discussion on this topic. And so any more questions from our audience, you can raise hand, any more discussions from our undergraduates and any fellow residents, feel free to ask the questions. So meanwhile, I'd like to ask sir, so can I put a question? Like we talked about, like there's a lot of work to be done in the primary level strategies, primary prevention, and the secondary prevention level measures. So actually we all know that non-communicable diseases can be prevented by lifestyle modifications. So what strategies we need to apply for enforcement of these lifestyle modifications and at individual as well as community level? So actually we are talking a lot, but the things are not coming out. So anything, any out of the box strategies?
What I think is that,
that we can
again regarding because what we have as risk factors are mostly behavioral or environmental. And if you were to look at the causes of the causes, then we need to go why people are doing that. So unless we, of course, one way to address it would be at the primordial level by addressing those whys. किन चाहिँ मान्छे चुरोट खान्छ, किन यो बच्चा चाहिँ स्ट्रेस्ड भएर रक्सी खान्छ अथवा you know, things like that. So those upstream things will need to be addressed. The causes of the causes will need to be addressed. But it's difficult to control the market, for example, to control the commerce and things. But you know, people need to be, the policymakers or so, we need to be mindful that, you know, those things also need to be addressed. You cannot just, you know, brush it under the carpet. So that would be one thing that needs to be done. Second thing, by primary, when I say primary, or even for primary and for primordial, I think what is needed is the multisectoral action or multisectoral approach at a very grassroots level. And जस्तै अब कुनै पनि एउटा ठाउँमा कुनै एउटा पालिकामा चुरोटको भनौँ न अब त्यो जुन त्यो एफसीटीसी अन्तर्गतको त्यसलाई पालना गर्ने नगर्ने भन्ने कुरा, त्यहाँको कुनै पसलमा चाहिँ जङ्क फुड बेच्ने नबेच्ने भन्ने कुरा, त्यहाँको मार्केटमा हेल्दियर अप्सन्सहरु ल्याउने नल्याउने भन्ने कुरा, त्यो चाहिँ इट हैज टु बी डन. अर्थात् त्यो त्यहाँ कुनै अब भनौँ न प्लेग्राउन्ड बनाउने भन्ने कुरा, पार्क बनाउने कुरा, इट इज समथिङ द्याट द लोकल पिपल निड टु डिसाइड. हैन, त लोकल पिपल भन्नाले नट ओन्ली लाइक द हेल्थ पर्सन. सो मलाई चाहिँ के लाग्छ भने आई डोन्ट नो, आई मिन जस्ट लाइक उहाँहरूलाई हामीले सिकाउन सक्नुपर्छ जस्तो लाग्छ, उहाँहरूलाई हामीले मोटिभेट गर्न सक्नुपर्छ जस्तो लाग्छ. र त्यो भएकोले आई थिङ्क द्याट यु नो द करेन्ट multi-sector action plan needs to really trickle down to the grassroots level. एउटा चाहिँ त्यो प्राइमरी प्लस प्राइमोडियलमा चाहिँ त्यो कुरा अर्को चाहिँ अब विदिन प्राइमरी बाई द्याट I mean, for example, somebody has already had the risk factor, is a smoker, takes chewing tobacco, has, is drinker, etc., etc. भने त्यसलाई चाहिँ हामीले कसरी रिभर्ट गर्ने भन्ने कुरा चाहिँ it has to be, through the, professional service. Professionally त्यो सर्भिसहरू एभाइलेबल हुनु पर्यो, जुन चाहिँ एभाइलेबल छैन अहिले हैन। अब मेबी अब सर्टेन सेक्टरले सर्टेन ठाउँमा दिइरा होला, अब मेन्टल हेल्थको कुरा गर्ने हो भने इट्स देयर, टिपिओहरूले गरिरहेको छ, तर अब ब्रोडली भन्ने हो भने चाहिँ इट्स नट एभाइलेबल, इट हेज टु बी एभाइलेबल एन्ड एक्सेसिबल। थ्याङ्क यू।
Okay, thank you, sir. So much elaborative, and obviously community participation would, I think we can say community participation and would increase to enforce those things. So now we have a lot of questions. So I think Dr. Pranil, please, your question, please unmute and.
Thank you. Thank you, Dr. Prerna, and thank you, Abhinav, for the enlightening presentation that you did. My question is focused on, let's say it's kind of a question regarding research in NCDs, where like whenever we, listen to leading, let's say cardiovascular epidemiologists, like Prabhakaran or other people, whenever they present their evidences from their countries, is based on long-term prospective cohort studies, multiple prospective cohort studies that they have done throughout their academic or professional career, and based on that there are lots of evidences that are generated. But in our context, I feel that we are, still far behind on that aspect. So only few long-term prospective cohort studies have been conducted so far. One I remember was back in Dharan, where we used to volunteer as students. The Dharan study that was led by Sanjeev sir, and the other the legal arts study. So, in your opinion, what is the main hindering factors? We know that there's scarcity of grants or grant writing capability among the researchers to undertake such a huge responsibility, and there is this problem of academic bureaucratic hassles as well. But so I was just wondering, what could be the new strategy in order to get this trend going in Nepal. Thank you.
Thanks, Pranil. If you ask me very frankly, I have very mixed feelings about the cohort studies. I mean, cohort study as a pure observational study. I do not doubt its capability, the evidence that we can generate out of it. But if we are doing it, for example, only to, let's say, find out the, the risk factors or the, disease incidents, probably, we need to look beyond cohort studies and have, because whether, let's say, the exposure A will lead to exposure B, and to what extent, so those information are more or less available, maybe not from our own population, but they are available. Having said that, having cohort studies will definitely give us a broader perspective. We will have, let's say, population from our own data. What I feel is really needed is the something that we haven't really explored is the genetic aspects or the ethical aspects of the things, or the sociological aspects of the thing. And cohort studies can actually give us that mileage, which is unique to our population, which is not there, and it cannot be extrapolated from the population beyond Nepal, for example. So having said that, cohort has a limitation, but it is important. But if you were to ask me why there is not enough, or let's say there is no such studies, but I think there will be. I'm sure there will be soon. I'm not hinting at anything, but I'm sure that it will come. It just needs, the collaborations just need to click at some level, and it will be there. So it's not like, Nepal is resisting it, or it is like, not trying to have it, or people are intentionally trying not to have Nepal, in a court study. It just needs to click. I recall I was talking to somebody in Sri Lanka, Dr. Chaudhary, who has done a bit of he's a young chap in cohort studies in Sri Lanka, in Bangladesh, Pakistan. We had almost made a deal, but then somehow it didn't work out. So things like it takes just one click to make things happen. So I'm sure it will happen one day. But at the same time, I think like if we can actually follow the population as a cohort with some interventions or some component of ill maintenance science, probably we'll get more than just some epidemiological association thing. That would be more important and I think interesting in our context. Thank you.
Thank you.
Thank you. I think now we'll move towards next question. Dr. Prajwal.
Dr. Prerna, can you hear me?
Yes, we can hear you, please.
Okay. Thank you, Abhinav, for your elaborative presentation. We learned a lot from your presentation. I have 3 questions to you. My first question to you is, does government has planned for any primordial prevention strategies for NCDs? And if yes, what is the strategy? But if no, what primordial strategies could be adopted, could be initiated in context of Nepal? First question. The second question is, you have been part of various surveys in Nepal, for example, STEP survey, NCDI Poverty Commission. What do you think about the validity of data presented in those reports? And my third question is, should we deal with the 4 major NCDs separately or in a broad umbrella of NCDs? For example, because cardiovascular disease is the leading cause of death, and a lot of young people are dying from CVD. So, is there a time that we think these 4 major NCDs separately? Thank you.
Thank you, Professor. यो प्राइमोडियलको कुरामा चाहिँ आई थिंक म नेपालीमा बोले पनि ठिकै हुन्छ होला। प्राइमोडियलको कुरामा चाहिँ अब गभर्नमेन्टले भनौँ न, स्पेसली यो लास्ट 5 years त्यसमा अब थ्रु भेरियस एभिन्युज, थ्रु भेरियस च्यानल्स नगरेको चाहिँ होइन। अब जस्तै अब स्पेसली फर टोब्याको, फर टु सर्टेन एक्सटेन्ट फर एल्कोहल, केही न केही चाहिँ भएको छ, त्यहाँदेखि भएको छैन भन्न पनि मिल्दैन। र जस्तै फर इक्जाम्पल अब यो भेरियस हेल्थ एजुकेसन मेटेरियल्सको माध्यमबाट पनि भनौँ प्राइमोडियल प्रिभेन्सन चाहिँ को कोसिस चाहिँ भएको छ। तर के छ त भन्दाखेरि ती जुन कोसिसहरू हो त्यो मात्रले चाहिँ प्राइमोडियल प्रिभेन्सनको अब्जेक्टिभ पुरा हुँदैन। इट्स द ट्रुथ। आई मिन यु मे गिभ पम्पलेट टु अ स्मोकर, अबले त्यो हेरेर ल म चोट छोड्छु, अथवा टिनेजर जसले चोट सुरु गरेको छैन उसले चाहिँ ल यो यस्तो हुँदो रहेछ म चोट सुरु गर्दिनँ भन्ने, इट मे इन्फ्लुएन्स लिटल बिट बट इट हेज गट इट्स ओन लिमिटेसन। त्यही भएकोले मोर फोकस्ड, मोर कन्सन्ट्रेटेड, मोर अर्गनाइज्ड इफोर्ट्सहरू हुनु जरुरी छ। द प्रब्लम इज फर इक्जाम्पल अब अघि मैले हाम्रो हार्दिक प्रोजेक्टको इक्जाम्पल दिएँ, त्यस्तै गरेर अब कतै फिजिकल एक्टिभिटीको भएको होला, कतै डायटको भएको होला। त्यो इक्जाम्पल्सहरूलाई, त्यसको लर्निङ्सहरूलाई लिएर गभर्नमेन्टले स्केल अप गर्न सक्नु पर्यो कि त्यो इक्जाम्पल्सहरूलाई उसले अरू ठाउँमा रेप्लिकेट गर्न सक्नु पर्यो होइन। त्यहाँदेखि अब इट मे नट बी पोसिबल एट त्यो संसारमा कहीँ पनि हुँदैन होला, तर वी मस्ट ट्राई। अब मैले जस्तै अब हार्दिकको इक्जाम्पल दिन्छु। आफ्टर वी कम्प्लिटेड, वी गट डेटा एभ्रिथिङ, NHICC मा धेरैचोटि त आएको थियौँ. See, this is something that has we have made like हाम्रो जस्तै अब भनौँ न यो फ्लिप चार्ट्सहरू सिम्पल नेपाली ल्याङ्ग्वेजमा बुझिने के अरे सानो किताबहरू we actually volunteered to give it to NHICC. हुन्छ रक्षा हामी विचार गरौँला भन्यो. Then it was never heard of. We didn't hear back. Follow up गर्यौँ भएन. त्यसपछि अब भनौँ न रिसेन्टली अब हाम्रो बागमती प्रदेशको हाम्रो नाम नलिउँ उहाँसँग पनि कुरा भएको थियो. I gave him like a bundle of all those materials. अनि हेर्नुस् तपाईहरु रिभ्यू गर्नुस्. I think this can be very useful for त्यो no response thereafter. अनि त्यसैले अब I don't know अब यो अर्को कुरा चाहिँ के भन्दाखेरि यसमा अब it's most of the things are driven by the global head, like I said, and sometimes it can be a double-edged sword. You tend not to hear to the local evidence. You tend not to listen to the local whatever you may call experts or something. त्यसले गर्दाखेरि पनि गाह्रो छ. यो गभर्नमेन्टको पोइन्ट अफ भ्यूबाट सोच्ने भने चाहिँ they don't want to take that risk जस्तो पनि लाग्छ मलाई कहिलेकाहीँ. Right? So, but I think we should always try. अब सेकेन्ड क्वेसन जुन चाहिँ सर्वेजहरूको भ्यालिडिटी कुरा छ. अब there is always a possibility of things not being done in the the way it should. त्यो सधैँ नै रहन्छ. So that त्यो चाहिँ त्यसले भन्नु कुनै पनि अब हाम्रो मात्र हैन कुनै पनि ठाउँको डेटालाई चाहिँ अलिकति क्वेसन मार्क त आउँछ नै. But it doesn't mean that those data are wrong. It doesn't mean that those data should be thrown into the dustbin. हैन अब हुन्छ सक्ला त्यो एकदमै 100% unbiased त्यसमा भए 5-10% यताउति हुन सक्थ्यो होला. But it doesn't matter. COPD को percentage 11.6 नभइकन 12.6 हुन्थ्यो होला अथवा 10.6 हुन्थ्यो होला. It shouldn't really matter. त्यो जुन slight change here and there. हेर्नुपर्ने कुरा के भन्दाखेरि where are we heading? हैन अब के छ त हामीले के गरिरहेका छौं त भन्ने कुरा र त्यसले चाहिँ हाम्रो भनौं ट्रेन्डहरुको त्योहरुको जुन हुन्छ त्यसलाई चाहिँ विचारमा as long as people are doing it wrong consistently, it's okay. मलाई चाहिँ त्यस्तो लाग्छ. So that the trend will show that okay, where are we heading? कुनै डेटामा चाहिँ अलि खराब कुनै डेटामा चाहिँ त्यो फ्याक्टरले बढी असर पार्ने त्यो भयो भने चाहिँ then it's a problem. But I think with supervision in place, with monitoring of data and everything, data rechecking and everything, these things definitely would be minimum, right? As far as यो जुन सेकेन्डरी डेटाको कुराहरु छ त्यसमा चाहिँ अब it is, for example, ICME को डेटाको कुरा it's based on the things that are there as small surveys. त्यसको एक्स्ट्रापोलेसन हुने हो. त्यसमा नेपालको आफ्नो डेटा भएन भने इन्डिया अथवा अरु देशको डेटालाई त्यसमा भनौं एक किसिमले प्रोजेक्सन गरेर त्यो फाइन्डिङ्सहरु आउने हो. त्यसको आफ्नो लिमिटेसन्सहरु हुन्छ फेरि. We cannot say that this is the real truth, but again it is better than having nothing, and it will of course give us a trend. Third question is sir. अब भनौं न यो जुन इन्टिग्रेसन भर्सेस त्यसमा चाहिँ I think integration is always better. किनभने there are shared risk. The approaches are shared among the diseases, among the risk factors. त्यसले गर्दाखेरि भनौं न अब it's difficult. It will be very difficult. It will be very resource heavy to do things. यो भनौं न फरक त्यसमा लाने चाहिँ it will not be cost effective. त नभनौं cost beneficial चाहिँ पक्कै पनि हुँदैन. So for now I think it should be together, integrated. त्यसमा अझ अरु पनि लिएर आउनु पर्छ. अरु NCDs हरु पनि neglected NCDs हरु पनि लिएर आउनु पर्छ. Kidney, for example, shouldn't be left alone, right? And मेजरमा चाहिँ integrated हुनु पर्छ.
Thank you very much. Thank you.
Okay, thank you for Dr. Prajul for your questions. We had two more hands raised by Dr. Deependra and Sangeeta Rai. So first, I would like to take Dr. Deependra Khatiwada. Kindly unmute and ask your question.
Thank you, Dr. Prerna. Can you hear me?
Yes, you are audible. Yes.
Thank you, Dr. Abhinav, for the excellent presentation and many things, very detailed about the NCDs. Just to be quick and few queries on, we have realized about which we have already discussed, the same implementation part of our intervention and strategies regarding NCDs in Nepal. My question to Dr. Abhinav will be, again, we already know not only in NCD programs, but also in other programs that if our programs are not people-centered, if they are not guided by the evidence and our data, and also now in present context, yes, we talk about multi-sectoral approach, and the more things are coming up for any successful implementation of any intervention or strategy we make at policy level. That is basically the one is like people-centered approach. Another is again the strong government and political commitments. Okay, and also the acceptance of any interventions by the community, by the people, thinking or realizing about all the cultural, social, economical barriers. So what do you feel as you've been working so many years in the cardiovascular disease prevention and control? What do you think will be the key points or the change maker for the NCD implementation in Nepal? Thank you.
If I were to put my money, I would say capacity building, Deependra, first thing, because mainly because see most of the policymakers, program implementers, they have a lot of experience with due respect and everything on communicable diseases and on maternal health, no doubt. But when it comes to the NCDs, the limitation of exposure is palpable. So I would say that capacity building is something that I would put my money on at every level, not only at the top level or at the federal level, but at every level. And from that everything will fall into place. Capacity building is not only about भएको चिजलाई युटिलाइज गर्ने मात्र हैन, रिसोर्स जेनेरेसनको कुराहरु आउला, that will kind of snowball into more people being capable of doing things, bringing in resources, technical know-hows and everything. Then एउटा त चाहिँ हुनुपर्छ, अर्को चाहिँ मलाई लागेको we need champions. So and we need champions in NCDs who are in the decision making place. यो कसैले चाहिँ जसरी भनौं न, अब if you were to look at maternal health or we can actually think of these pioneers were actually the ones who actually led the country to जस्तै अब भनौं न आज भन्दा 40 वर्ष अगाडि film planning भने कहाँ थियो र? Now we take film planning as यो त program as भइनै रहने चीज हो, and it's like a routine thing. Immunization भनौं न अब 1970s मा कहाँ थियो immunization? It all started from somewhere. हैन, मान्छेको त्यसमा क्यापेसिटी बढ्दै गयो. There were champions, people who actually kind of pushed it through. Then त्यो भयो भने चाहिँ पक्कै हुन्छ. And I think यसको पनि I think the pathway or the trajectory is going to be similar. And यो अहिले नै सबै एकैचोटी हुन्छ भने एक्सपेक्ट गर्नु पनि हुँदैन. तर यो हुने क्रममा चाहिँ what we can contribute, how we can work together, र कसरी चाहिँ यसलाई हामीले पुश गर्दै जान सक्छौं भन्ने कुरा नै मेरो विचारमा महत्त्वपूर्ण कुरा हो जस्तो लाग्छ. मेन क्यापेसिटी एन्ड रिसोर्सेस, त्यो दुईटा चीजमा म फोकस गर्छु. And having champions, at the decision-making levels. Yes, thank you. I hope I addressed your question.
Yeah. Yes, thank you. And also one small last question. So, do you think like we Nepal are like missing more NCD leaders? Maybe we need more leaders who are working in NCD, in prevention and control.
Definitely. Many of us are there. हामी अझै पनि डिसिजन मेकिङको ढोका भन्दा बाहिर बसेर काम गरिरहेका छौँ हैन हामी अब we are there but we have limited authority by I mean many researchers like me, many policy influencers अब जस्तै भनौं न अब a young colleague of mine, he has done systems research in NCDs, right? अब उसको contribution is enormous in terms of research, but who is going to utilize that information? I know. NHRC has definitely tried, but it has to be more often. It has to be more specific. And this, for example, NCD problem, or it might be somebody else. I don't know. Okay, what is the evidence that we have right now? त्यसलाई एक ठाउँमा ल्याउने, त्यसलाई त्यसपछि युटिलाइज गर्ने त्यो ब्रिजहरु चाहिँ एकदम आवश्यक छ. So in terms of NCD leaders, if there are more outside the country or they decide to stay outside the country, not contributing or not trying to enter the room, then probably things might not change. We may have, a very good volume of research, but how much of it will actually translate for actual change, त्यो चाहिँ हुन गाह्रो हुन्छ. त्यही भएकोले leaders from within the country, within the ministry, within the भनौं न अब EDP, etc., and academics, if they can come together and work on it, definitely, अहिले जस्तो त्यो भन्दा भयंकर रूपमा काम छिटो अगाडि बढ्न सक्छ जस्तो लाग्छ. We can accelerate things a lot, than how it is right now.
Thank you, Dr. Abhinav. Thank you so much.
Okay. Thank you, Dr. Deependra. Obviously, indeed, capacity building is the key because we have a lot to do. So we need the manpower, the people who have to work there for that. So next question we have from Sangeeta Rai. Are you there? Kindly introduce yourself and put on your question. Sangeeta Rai.
Hello.
Yes. Please go ahead.
Namaste. And thank you, Dr. Prerana, and thank you, sir, for your nice presentation. म चाहिँ डाक्टर संगीता राई हो. म चाहिँ सामाजिक विकास मन्त्रालयमा स्वास्थ्य महाशाखामा काम गरिरहेको छु. यो जुन प्रिभेन्सनको कुरा हामीले गरिरहेछौँ, अनि प्रिभेन्सनमा चाहिँ हाम्रो आयुर्वेद ले चाहिँ एउटा कस्तो भन्दाखेरि इम्प्लिमेन्टेसन गरेको रहेछ नागरिक आरोग्य कार्यक्रम, जुन चाहिँ प्रिमोरल प्रिभेन्सनमा को मेन जस्तो नन कम्युनिकेबल डिजिजलाई फोकस गरेर बनाएको रहेछ. मैले जुन त्यो प्रोग्राम प्लान पोलिसी गर्दाखेरि चाहिँ एउटा ड्राफ्ट हेरेको थिएँ, जुन चाहिँ आयुर्वेदको सरले मलाई सेयर गर्नुभएको थियो. अन्त यतिखेर प्रिमोडल प्रिभेन्सनमा आयुर्वेदले गरिरहेछ भने हामीले चाहिँ किन नगर्न सक्ने भनेर क्वेसन मलाई आफै उठेको थियो. अन्त यति बेला चाहिँ मैले उहाँले चाहिँ के सजेसन दिएको थियो भने प्रिमोडल प्रिभेन्सनमा चाहिँ यो गर्न सक्छ भनेर भनेको थियौँ. अनि यसरी नै हाम्रो नेस्कममा जुन एनसिडी को कुरा सरले दिनु भएर इन्ट्रेस्टेड नै भएर मैले टाइम निकालेर यो सुन्दाखेरि चाहिँ राम्रो लाग्यो. सरले जुन पोलिसी मेकिङ गर्दाखेरि बनाउनु भयो सरले त्यो भेरी राम्रो कुरा हो. यसरी नै हामीले प्रिमोडल मा चाहिँ हाम्रो जुन हामी चाहिँ कम्युनिटी मेडिसिन भनेर जहिले पनि भनिरहेको हुन्छौँ, तर हामीले के गर्छौँ भन्दाखेरि हामीले चाहिँ जहाँ नपुगेको कुरालाई चाहिँ हिट गर्यो भने चाहिँ राम्रो हुन्छ जस्तै लाग्छ. मैले चाहिँ जस्ट इन्फर्मेसन गर्नुको लागि चाहिँ यो नागरिक आरोग्य कार्यक्रम भनेको चाहिँ प्रिमोडल प्रिभेन्सन र प्राइमेरी प्रिभेन्सनको लागि ठुलो मात्रामा चाहिँ हरेक लोकल लेभललाई नै टार्गेट गरेर र माथि केन्द्रबाटै नै आएको प्रोग्राम हो। अहिले चाहिँ हरेक आयुर्वेद अस्पतालहरूले चाहिँ यो आरोग्य कार्यक्रम गरिरहेको रहेछ। त्यसमा चाहिँ हामीले पनि केही मल्टिसेक्टर एप्रोचले नै गर्यो भने चाहिँ अलिकति राम्रो हुन्छ र फ्रुटफुल यो NCD को जुन रिस्क फ्याक्टरहरूलाई चाहिँ हामीले प्रिभेन्ट गर्न सक्छौँ जस्तो लाग्छ। हुन्छ, यही भन्नुको लागि मैले मेरो यो 2 शब्द राखेको हो। थ्याङ्क यू, धन्यवाद।
हजुर, थ्याङ्क यू सङ्गीताजी, एकदम राम्रो कुरा गर्नुभयो। र इनफ्याक्ट अब यो जुन हाम्रो भनौँ न अल्टरनेटिभ मेडिसिन भनेर पनि भन्छ, वैकल्पिक चिकित्सा भनेर, होइन। र यो मल्टिसेक्टर एक्सन प्लानहरूको त्यसमा पनि यो भनौँ न आयुर्वेद अरू हाम्रो चिकित्सा पद्धतिहरूको कुरा एकदम बारम्बार उठ्छ नै। र यसमा पक्कै पनि अब कस्तो भने एउटा प्यारलली गएर चिज जस्तो भइरहेछ कि। र तपाईँहरूलाई एकदम ज्ञान नै होला। अब त्यो भनौँ न, जस्तै हाम्रो जुन हेल्थ आउटलेट्सहरू छन्, जस्तै अब हेल्थ पोस्ट भनौँ अथवा PCC भनौँ, अथवा त्यो र आयुर्वेद रिलेटेड कुनै एउटा आउटलेटको बिचमा चाहिँ कसरी समन्वय गर्ने भन्ने कुरा चाहिँ एकदमै एउटा छलफलको विषय हुने गर्दछ सधैँ। र कति कुराहरूमा चाहिँ अब होइन, अब इन्क्लुड गरौँ भन्ने हिसाबले चाहिँ कुरा आइरहेको हुन्छ, तर इम्प्लिमेन्टेसन भइरहेको हुँदैन। र यो भनौँ न स्पेसल्ली NCDमा चाहिँ पक्कै पनि यो आयुर्वेदले चाहिँ तपाईँले भन्नुभएको जस्तो लोकल लेभलमै चाहिँ धेरै चिज गर्न सक्छ। त्यसको इनफ्याक्ट प्रमाणहरू पनि छन् है। जस्तै अब मलाई ठ्याक्कै याद आएको भनेको चाहिँ हाम्रो डाक्टर राजाराम ढुङ्गाना, उहाँहरूले यो योगाको त्यसमा पब्लिसै गर्नुभएको छ, राम्रो पेपर्स। तर त्यो पेपरलाई चाहिँ अब हामीले को आधारमा ल यसो गरौँ भनेर इम्प्लिमेन्ट गर्ने चाहिँ कसले भन्ने कुरा आयो कि फेरि त्यो एभिडेन्सलाई चाहिँ ल टेकअप गरेर हाम्रो कम्युनिटी इन्टरभेन्सन फ्रेमवर्कहरूमा यो राखौँ न भन्ने चाहिँ कसले भन्ने कुरा आयो कि। त्यहाँदेखि यसलाई मैले एकदम पोजिटिभली लिएँ। तर यसलाई चाहिँ कसैले चाहिँ एड्रेस गर्नु पर्यो हेल्थ सिस्टम भित्रबाटै। त्यसलाई चाहिँ म फेरि इम्फेसाइज गर्न खोजेँ। हस्, थ्याङ्क यू।
Thank you, sir. Sangeeta ji, thank you so much for your input and your query. And it's very, it is very glad that we have audience from other sectors, and equally they are opening doors, how to collaborate and how to move forward. And already, as we are a society of lot of community medicine graduates who can be leading roles in the field like that of non-communicable diseases. So any more questions from the audience? Anything, any comments? Anybody would like to speak something, you can unmute, and any suggestions, advices, can put in the chat box. So I think if no more questions, I'd like to quickly summarize what we did today. And I'd like to first of all thank a lot to our speaker today, Professor Dr. Abhinav Vaidya. And as we started, we almost crossed about 30 minutes. Yeah.
Sorry.
Yes, sir.
Dr. Nikki le haat uthaiरहनु भएको छ.
Okay, sure. Dr. Nikki, please kindly unmute. Dr. Nikki.
Yeah, hi, Prerna. Can you hear me?
Yes, ma'am. Very clear.
Okay.
Please go ahead.
No, I just wanted to congratulate Abhinav for a great presentation. I think it was very succinct, very comprehensive, and very informative. And I liked everything about the presentation. I especially liked the part, Abhinav, where you said that the advocacy has to come not only from the professionals, but it has to come from the sufferers and from the people themselves who have been facing the NCD problem and the NCD wrath. So I think that's something very few people think about, or very few of us are probably aware of. I think if we can make an impact at that level in terms of advocacy, I think that would be a great start. Thank you, Abhinav. It was a great presentation, and it feels great to be your friend and your colleague, and it was a wonderful presentation. Thank you so much.
Yeah, thanks, Nikki. Thank you.
Indeed, ma'am. So we all had a very fruitful session today. This evening was quite beneficial to each and everyone, all of us present here. So today's, first of all, again, I'd like to thank a lot to Professor Dr. Abhinav Vaidya for sparing his time, and almost we have done 45 minutes above discussion, and that's really wonderful, out of our expectations. And still we have around 49 participants from the beginning, and that's quite unusual for any webinar. So everybody is so sticked and is taking a lot of benefits from this webinar. So I'd like to quickly summarize for all the events. First of all, thank you, NESCOM. Thank you, all the team members of webinar team that we were successfully able to conduct our second webinar. And so we started off with Dr. Nikita introduction, and then gave the introduction of Professor Dr. Abhinav Vaidya. And in his presentation, and all the areas was included, right from what actually is the burden, whether it's an epidemic, are we ready to call it epidemic diseases, or the fact that we are heading towards an epidemic, and also what a very detailed look into what is being done in Nepal. And as he has been a part of the national program, he's been working a lot of associations, and we could I myself not so much involved in terms of okay. Am I audible?
Yes,
Dr.
ma'am.
Nikita?
Yes, ma'am.
Okay. Okay, sorry for the internet problem. Okay, so actually that's how would I like to summarize, like we were talking about how we have evolved in terms of the national program, how it's now being emphasized on, but there is a lot of more work to be done in the terms of financial budget, in terms of advocacy, in terms of capacity building, and overall national non-communicable disease program. So unmute. Okay, yeah, that's fine. And of course, so there's the most important part is the scope that we have towards working in NCDs. And I think it's been quite clear that there's a lot of scope there. We need leaders, but we have to do towards capacity building. It is training, learning, and grabbing opportunities, guiding. So I think this is the first door open, and we would move ahead with such discussions in future. And so with that note, now I think I'd like to end the webinar session for today. And for the closing, I'd like to hand over to Dr. Nikita. Thank you.
Thank you so much, Prerna ma'am, for your kind words, for summarizing what you've just said. I would like to thank Dr. Abhinav for imparting his vast knowledge in such a short amount of time to our participants. It has definitely created a better understanding about NCDs in Nepal. The webinar wouldn't have been possible if it wasn't for Dr. Prajwal and the whole organizing team. I would like to acknowledge our technical partner, NREN, for their support. Last but not the least, I would like to thank the participants for taking out time and still being with us at the end of 2 hours. I hope it was a fruitful one. We have scheduled another webinar on the 2nd of January 2022 by Dr. Dipendra Khatiora. He is a surveillance medical officer at WHO, and he will be talking about immunization and COVID-19 vaccination, possibilities and challenges. We will provide more information on our Facebook page. So I hope to see all of you in the next webinar as well. So thank you all and good night.
Well, thank you, everybody. Take care.
Thank you, Daya. Thank you very
Stay
much.
well. Stay well.
Thank
Bye-bye.
you all.
Bye-bye.
Thank you.
अरू नजाने कि के हो एकदम यो अनलाइनै बसिरहेको भएकोले ल बाय बाय ल दिपेन्द्र लुकिङ फरवर्ड टु योर प्रेजेन्टेसन है इन 2 weeks